Thank you. Thank you very much. Hello, everybody, again. It's a great pleasure for me to share with you some insights into AI and the future of radiology. As you probably know, I mean, the amount of data that is being generated in healthcare is simply mind-blowing. Just give you a couple of data points here. In 2010, 15 years ago, it was estimated that it took 3.5 years for medical data to double. And in 2020, only 10 years later, 5 years ago, this was 0.2 years. And 0.2 years is 72 days. I did the math. And 72 days from now, you know, November 8th is like mid-January. If you think about it, you know, mid-January, the data will have doubled again. And again, this is data from 2020. And I just heard a couple of weeks ago a professor from Harvard talk that this double time is only 5 weeks. So it's just incredible, you know, the amount of data that is generated in healthcare. There is more information in a digital mammogram than there is in the phone book of Thessaloniki, if there really still is a physical one. I don't know. I haven't seen a real phone book in a long time, you know. There are more than 6,000 medical journals with approximately 1 million peer-reviewed papers every year. So, you know, just think about it. So even the best human brain cannot process all this data. And a final number from the US, 15 years ago, a radiologist would look at around 500 images in a 12-hour shift. Now, theoretically, it's 25,000 images. So it's really, really unbelievable. I don't want to bore you with the data, with numbers, but I have to show you two more numbers. You've probably heard about the number on the left-hand side, 50 petabytes. That is the amount of data a normal-sized hospital, not even a huge university hospital, is generating every year. And what is a petabyte? I mean, I'm a radiologist, I'm not an IT guy. 1 petabyte is the one with a lot of zeros, right? But to make it more tangible, if you compare it to the most, I would say, undigital thing that many of us like so much, the book, this would be 8 billion books. So every year, you know, a normal-sized hospital is generating data, and this is the equivalent of 8 billion books, or 53 times the British Library. And the number you can see on the right-hand side is even more, is even more incredible. 97%. 97% of all data that is generated in healthcare is never looked at, directly goes to the archive. Let me repeat that. 97% of all data that we are generating in healthcare, you know, we are not looking at. It directly goes to the archive. It doesn't necessarily mean that all that 97% is meaningful data, but I'm sure, you know, that there must be some kind of data or data points that we can use, you know, to be able to predict the course of disease in a patient. So to cut a long story short, in healthcare, we've been very good in generating data, but there is room for improvement to turn this data in actionable insights. And now think about it. Is AI the panacea? Will AI be, you know, that tool that helps us to digest all this incredible amount of data? And before I go a little bit into AI and healthcare, just think about this question here. Will AI become humans' last invention? It sounds a little scary, but think about it, you know, because everything that will be developed from now on, you know, will be generated and also, you know, developed with the help of AI. And when you look at the healthcare system, I see basically 3 levels where AI and analytics can help in the healthcare system. There is the individual level. What do I mean by that? We are implementing AI capabilities right into our machines, into the CT scanner, the MR scanner, the ultrasound machine, into conventional X-ray. Then there is the departmental level. That means we are using AI to streamline workflows in radiology departments. This is more like the non-pixel AI part. And we can even elevate this and have the enterprise level where we can use AI to really streamline workflows in entire hospitals or even network of hospitals. And let me give you a couple of examples for each of the three. Let's start with the individual level. Well, I think you don't have to be a physician to see what this is. This is a chest x-ray. And one of the conditions ICU doctors really fear in healthcare is a collapsed lung, a pneumothorax. And it's no rocket science to treat it actually, but you have to know that the patient has a pneumothorax. Again, data from the US, it can take up to 12 hours till an x-ray, which is done probably in the middle of the night by the tech on the ICU, is really looked at by a radiologist, and it can be potentially deadly if not treated on time. So what have we done a couple of years ago? We have implemented AI capabilities into a mobile x-ray system. And so this x-ray system, first of all, does a quality check. So when the tech is doing the exam on the ICU, it tells you, have you done it properly? Can we see the entire lung? Is it really AP and not oblique? And in addition to that, it gives you a so-called heat map. And this is an algorithm implemented into the mobile x-ray machine, that is able to detect a pneumothorax. And it not only shows you the heat map, it gives you a probability score. So in this case, in 96%, there is confidence that this patient has a pneumothorax. And just imagine the scenario. It's 3 o'clock in the morning on the ICU. The tech is doing the exam, sees that. Then the tech can call the radiologist. There is probably only one radiologist in the hospital at night doing a trauma case in the emergency room, looking at a CT. And then the tech can send this study with high priority into the PACS system and call the radiologist, please look at that image first. It's very important for me to tell you, this is not about whether the AI, is better than the radiologist or the radiologist still outperforms the AI. It's just about prioritizing critical cases. And we introduced this 3 years ago, and we really get a very good feedback from the clinicians. Now let's switch modality. We go from conventional X-ray to MR. And here you can see a deep learning algorithm that is almost completely reducing the noise of an MR image. And we call this Air Recon DL. And this translates into better image quality. Just to give you another example, lumbar spine, it's the same scan time, it's the same voxel size, it's the same raw data, and you can be the judge yourself. You have the noise removed, and you have a higher image sharpness that hopefully translates into a diagnosis that you can do with more confidence for the clinicians and for the patients. So let's again move the modality. And some say this is the new stethoscope. Well, it's a little bit more expensive still than the stethoscope, but this is a mobile ultrasound system. We call it vScan, with 2 transducers that is able to generate images with exceptional image quality. And if you take a look here, this is an example of the carotid arteries. You can measure the intima media thickness. And although not initially developed for OB-GYN applications, you can see here a pregnant woman, you can see the umbilical vein, the umbilical arteries, just to show you that the image quality is really, really good. And think about it, there is implemented AI in it. The topic is, and usually ultrasound is very user dependent, and we would like to democratize ultrasound. Just think of areas on the globe that have room for improvement with regard to access to care. rural India, some parts of sub-Saharan Africa, and there is a pregnant lady, and the lady suffers from pain. And now, as someone, there probably is no doctor, probably not even a midwife, there is a physician helper that is now doing the ultrasound exam to see if the pain she is having is normal as part of her pregnancy, or if she probably has to travel 9-12 hours to the next polyclinic. There is implemented AI that really also gives the not so experienced user clues. Okay, this is the artery, this is the vein, please angulate by 10 degrees. It really gives you commands how to perform or how to generate a proper ultrasound image. Let's take a look at the next level, the departmental level. I mentioned this is more the non-pixel AI part, so we use AI not to make the image better, but to streamline workflows in radiology departments. And we have developed an algorithm together with a customer from Switzerland, Professor Schindera from Aarau, that is predicting the likelihood of a patient not showing up for his or her exam. So it's called the no-show app. You know, it's very annoying. You have reserved 45 minutes of scan time, and without calling, the patient simply doesn't show up, and you have lost that slot. The CFO of the private imaging center is not amused. If you are lucky, you are attached to a hospital, and maybe you can call a ward, and there is an emergency list, and if you are lucky, the patient is there and not smoking outside, so you can probably get that patient to fill the slot. But most of radiology imaging centers are not in a hospital, but they are like outside, standalone in pedestrian zones, so we have definitely lost that slot. So what have we done? This algorithm takes into account many so-called predictors, the weather forecast, you know, the traffic jam, the traffic situation, and this not only works in Aarau, where it was developed, it works in Sao Paulo, it works in Seoul, it works in Berlin. So there are a lot of predictors. There are also easy things that have nothing to do with deep learning. It's like when you make a restaurant reservation, you get an SMS 24 hours prior. This is what is also included, and it's also looking what is the history of patients showing up, if this is a returning customers. And quite frankly, I mean, you don't need AI to not schedule an appointment for a student on a Monday morning, because I mean, we were all students, no one would show up. You don't need the AI for that. But it's really amazing, and there are studies that have been published that could really demonstrate a significant reduction of the no-show rate. What is very important for me is that the digital transformation is not done, you know, within a week. You cannot say, okay, I buy a couple of apps and from Monday on, I'm going digital now. It's a really strategic decision that you need everyone to buy into. You know, not only the radiology department, but also the IT. Ideally, the C-suite is all in, and you not only need, you know, customers who are just or colleagues who are just willing to accept the new situation, but you need kind of ambassadors. You need change agents. You need people who really burn for this, and this is very important. It's strategy and not technology that drives the clinical applications and innovations. And finally, there is the enterprise level. Here we can use AI to really take care of patient flow, patient experience in entire hospitals or even network of hospitals. And this is a view not of the tower of Thessaloniki Airport, but here you can see a so-called wall of analytics. This is a lot of TV screens in one room in a hospital where you have full transparency, of empty beds, of clean beds. I give you an example. When I did my residency in radiology, at the time we had to do 1 year outside of radiology. So I did internal medicine, and I was on call at night, and I had to find a bed for a patient in the middle of the night. And at the time you would call a ward, and you would say, hey, look, do you have a bed for my patient? And the nurse would say, I'm so sorry, Matthias, we are completely full. Then you would call the next ward, and you got the same answer, and you could never be 100% sure if this was true or not. Maybe it was just a bed reserved for an important patient coming the next morning. So here, all of a sudden, no one can lie because you have full transparency. Even if you have a cardiology patient, but you see in urology there are 3 empty beds, so you can admit that patient into the hospital. This is called command center. We are working with a lot of customers to really add virtual beds, because there are studies out. If a bed is used better, you can calculate this, that you can, by using this command center solution, adding virtual bed into your hospital. I don't know if any one of you knows 50 Shades of Grey. Of course, everyone knows it, but no one has seen it. I can tell you I've seen it. I was not really impressed, but that's another story. Look at this horizontal bar, and believe it or not, it's the same color from left to right. And you can prove that if you cover above and below with your hands, and I always love it when I see the audience doing this, and all of a sudden you see that this is the same gray. The human eye is able to differentiate 10 million different colors, believe it or not, 10 million different colors, but only 45 to 50 shades of gray. And if you're older than 50, it's 32 shades of gray. So why do I show this to you? Just to quickly talk 1 minute about radiomics, a very exciting field in radiology. So you look at an image. The best radiologist, not me, looks at an image with the best human eyes, not me, I'm short-sighted, and says, this is a normal finding. And he or she is right. This is a normal finding. But then an algorithm looks at this normal finding, and this is called feature extraction, and sees imaging features that invisible to the human eye that are probably not normal. In order to do this, you need data at different time points in the patient journey, and ideally you need to know the outcome of that patient. What happened, is the patient still alive after 5 years and stuff. And then all of a sudden you have a cohort of patients, because what is the goal? We want to catch the tumor in stages 1 and 2, so that we have more treatment options, or the clinician, our clinical colleagues have more treatment options. And then all of a sudden you have a cohort of 100 patients, and then Matthias comes, patient 101, and I get a cancer diagnosis, but then the doctor can tell me, hey, look, in a similar cohort, 96% are still alive after 5 years. So this is predicting the course of disease. I mean, I could talk, this is a hot topic. We could do an entire session on this. I just want to tell you, radiomics, very, very important. Because there is not one cancer, there is not one breast cancer, there is not one colon cancer. Every cancer is individual. And this is our mantra at GE Healthcare, precision health, doing the right thing at the right time for each and every patient. And now coming back to us, the physicians, will AI mean the end of doctors? And I'm biased here, being a radiologist myself. Just think about it. I mean, who wants to sit in a plane without a pilot? The autopilot has not replaced the human pilot, but has expanded their capabilities. At almost every airport in Europe, a plane can automatically take off and land. But I mean, come on, who would like to sit in a plane without a pilot? I don't know if you remember Chesley Sullenberger, that positive, crazy pilot who landed an Airbus A320 in the Hudson River. This is 16 years ago. Luckily, we have no control group, but I doubt that an AI would have landed the plane. What I want to say is, AI is great for repetitive stuff, for boring stuff in radiology, also my former boss, said you cannot say boring stuff in radiology. Nothing is boring in radiology. I say, sorry, there is boring stuff in radiology. Measuring 55 lung metastasis in a patient with known colon cancer in Germany, at least for medical legal reasons, you have to do it once and measure them. I mean, it's a no-brainer. AI comes in and, in 5 seconds, this is measured. But when it comes to situations, I mean, sometimes I guess the old school gut feeling is needed. So will AI ultimately replace the radiologist? And I say AI per se will not replace the radiologist. What I also say is that radiologists embracing the power of AI will mid and long term replace those who don't. So let me conclude. Artificial intelligence is here, and it is here to stay. It's not science fiction, it's science fact. I think with AI as your invisible friend, we can see more, we can diagnose disease faster and more accurately. And I'm a great fan of Eric Topol, the cardiologist, used to work in Cleveland, now in San Diego. I don't know if you know his book, Deep Medicine. He says, and it sounds a little, funny, artificial intelligence will make medicine more human again. Because, again, the repetitive stuff, the boring stuff, we let the AI do, so the radiologists can get out of their dark rooms and get back into the daylight and be an integral part of the care team, and can also communicate results with his colleagues and with their colleagues and with the patient. So I would really recommend to embrace AI responsibly, embrace AI, but don't fear it. So in summary, I go back one because you wanted to take a photo. Yes. Here we go. So in summary, the next 5-10 years will bring big opportunities, including massive convergence of technologies. And we all have to work as a collaborative ecosystem to really be able to successful. And of course, we'll leverage data. AI will help us to kind of digest all this incredible amount of data. But what I also say, healthcare needs human touch. When I go to my doctors, I don't want to get a diagnosis from a computer. I want to talk to a real person, my doctor friend, a nurse. And if that person came up with a diagnosis based on AI, I love it. But I need this human touch, this human interface. And this is my firm belief, this will never go away. Final slide, I'm active on LinkedIn. If you want to follow me or connect with me, and if you have your mobile phone ready, you can directly scan the QR code. Otherwise, you'll find me on LinkedIn. And with that, I'd like to thank you very much for your attention.